Good afternoon. Thank you to Dr. Rujul and the organizers of the Masterclass for this opportunity to interact with you and present a briefing about pediatric anesthesia and some information about my department and about what we do. What I'm going to do is give you a brief introduction of pediatric anesthesia, the scope and the span of pediatric anesthesia, and give you a glimpse of really what we do in the OT and in other areas that we offer our services. So pediatric anesthesia, as we all know, is a specialty of anesthesia that covers the spectrum of life, and really we deal with the extremes, starting with vulnerable neonates and extending into adolescents. Some of our big patients are as good as young adults. And who makes a pediatric anesthetist? Really, it is a specialist anesthetist with training in pediatric anesthesia. So beyond our basic training in MD or DNB, what our team undergoes, or what a pediatric anesthetist undergoes to become a pediatric anesthetist, is at least a 1-year fellowship course, which are offered by many universities in the country and some associations. We also have the 2-year DNP course offered by the Diplomate of National Board, and we have both these courses going on in our hospital as well. So we have the 1-year fellowship, which is conducted by the Indian Association of Pediatric Anesthetists, as well as the 2-year course, which is offered by the DNB. In addition, certain institutes, as of now, offer the DM, which is a 3-year specialist course in pediatric anesthesia. Currently, it is offered at KM Hospital under the MCI and also at PGI Chandigarh. So my team, comprising of 8 anesthetists, are at least, they have at least a fellowship. Some of them are DMs in pediatric anesthesia. In addition, we have a very robust pediatric cardiac anesthesia team, and our pediatric cardiac anesthetists have got formal training in cardiac anesthesia, which would be at least a fellowship, if not an FMB or the DM, pediatric cardiac anesthesia. So this is us. We are 8 consultants in the department, and we are a full-time department, always stationed here. So we offer 24/7 services. And in addition, we run the fellowship course. So currently we have 2 fellows with us, Dr. Sridivya and Dr. Dixita. Besides me, Dr. Vaibhav, Dr. Lopa, and Dr. Naveed and Dr. Saumil are the cardiac anesthetists. And then we have Dr. Hardik, Dr. Priyanka, Muneshwar, and Dr. Vedhika, who manage the general anesthesia services along with me. So what is the patient population we cater to at SRCC? Our patient population spans from newborns to adolescents, like I said, up to 18 years of age by the book. But there are certain patients followed up with us beyond 18 years. These are special kids who've been following up with us, and especially during their transition to adulthood. We permit these patients also to be under our care. In addition, we also have fetal interventions, and so these mothers are admitted with us and they undergo fetal interventions for certain conditions, such as we've done cases of twin-to-twin transfusion syndrome, some bladder outlet obstructions, and we also take care of these mothers and also these babies when they're undergoing these procedures. So this is what we do, our scope of services. So primarily you will find us inside the operation rooms, where we have everything under one roof. So general pediatric surgery, cardiac surgery, orthopedic surgery, plastic, neurosurgery, ENT, ophthalmic procedures, pulmonology, dental procedures, and hematology procedures. So this is where the scope of services within the operation theatre. But beyond this, we also offer our services, which is sedation or general anesthesia, in the outside OR locations, which would be MRI, CT scan, cath lab, and some emergency procedures as well. Now, us being a children's hospital, unlike adults, although these procedures, many of them may not be painful, but still we have to, either sedate or anesthetize these children. So that's why our scope of services is quite varied and is quite vast. In addition, we are experts in vascular access. So we often get calls for inserting central lines or PICC lines, especially in our BMT colleagues ask us to help them out. And there are times when you have kids with very difficult vascular access, and we put in lines ultrasound guided very often. And I remember a case where where this child could not be anesthetized outside in a nursing home because they just couldn't get vascular access, and this child ultimately was managed with us in the operating. It was an orthopedic case. Beyond the operating room and beyond managing anesthesia and pain inside the operative room, we also manage post-operative pain, which essentially comes under acute pain management. So we follow up our patients post-operatively. Some of them are shifted to the wards if the pain is not that severe, but some may be in the ICU. And we also round these patients and offer comprehensive pain services, which could be nerve block catheters, which could be epidural catheters, which could be sometimes peripheral nerve blocks, and or sometimes just multimodal analgesia, and we take care of acute pain as well. In addition, like I said, we have been doing some fetal interventions, and this is where we manage the maternal side as well by offering sedation or monitored anesthesia care, or sometimes it is an intervention like a spinal, so that the fetal intervention can be enabled. There is a dictum in anesthesia where we say children are not small adults, and infants and neonates are not small children. So what makes them different, and why does it take a pediatric anesthetist to manage these children? It's because, as we all know, and as you all know, the children are different. They have different anatomy, they have different physiology. The disease processes are often quite different from adults. For example, you would quite commonly find an adult with ischemic heart disease or diabetes, whereas in children it's more often they have some syndromes, they may have some acute lung condition. We have congenital heart diseases, which occupy a significant portion of our patient load. Their pharmacology is different. They process drugs differently. The drug dosages have to be meticulously calculated. And we also need specialized equipment for managing these patients, because these patients don't come in one size like most adults would do. So we have to have the entire spectrum of equipment, right from managing a premature neonate to a big adult. So all in all, pediatric patients, we have a reduced margin of safety, and there is really no failure. This is just to give you a glimpse of how prepared we have to be when we are taking in a patient. And an adult will most often walk into a theater, and then you can take your time putting in a pulse oximeter probe, putting an ECG lead on, and things like that. They will allow an IV cannulation. But when it comes to a pediatric patient, you have to be really prepared with absolutely everything. And it comes to the small things that you have to pay attention to, like the temperature in the operating room. Here we have a patient on the left-hand side. You see how in the preparedness we have the the shoulder ready so that the airway can be kept open. We have the monitoring equipment ready. The warmer is in place and things like that. On the right-hand side, the array of equipment. This is for a small baby, I would presume. So you have the small blade laryngoscope and so on and so forth. So basically paying attention to the small things is an important part of what we do. Again, this is just to show you how we have to calculate the drug doses meticulously and give it in appropriate doses, most often based on weight. So this was a paper which was published in Anesthesia, and it talked about critical events in pediatric anesthesia. This was a paper from the UK, and this was an analysis of what is called the apricot study, which basically meant anesthesia practice in children. It was an observational study, and it was a big study, over 30,000 children, 261 hospitals across 33 countries in Europe, and they found that the incidence of perioperative critical events was about 5.2%. And the risk factors for these critical events were young age, previous medical history, and the physical condition of the patient. And what conclusion they drew from this trial is that they looked at certain red flags in pediatric anesthesia, which meant neonates, infants, children less than 3 years, children with congenital and metabolic diseases, or children who are sicker. And we have the ASA, the American Society of Anesthesiologists classification for that. So sicker children, syndromic children, children who are going to undergo major complex surgery. And what the recommendation is that these patients should be cared for by anesthesiologists with specific education, specific training, and ongoing experience in pediatric anesthesia. Medication errors in pediatric anesthesia. This is a report from the Wake Up Safe Quality Improvement Initiative. This is from the United States. And medication errors make up the third highest category of errors of after cardiac and respiratory related events. And they actually categorized medication errors. And we know that medication errors can occur at several times. It could be during the preparation of medication, it could be during prescribing, it could be during administration. And this is why we have to be very, very careful in when we are anesthetizing or sedating children. So what does it take to be a pediatric anesthetist? Of course, you need knowledge and skills, but we also have to be gentle. We need dexterity and finesse to manage these small patients. Communication skills are a very, very important and integral part of what goes into the making of a pediatric anesthetist, because we don't only treat the patient, we actually manage a family. So often you have the parents, the grandparents, maternal side and the paternal side, everybody is there. So, and actually it takes a whole lot of talking and speaking and explaining what we do. And there are a lot of concerns when it comes to anesthetizing a child, especially for the entire family. And again, like I said, paying attention to the small things. This is to give an idea about how we administer fluids. So you can see as we have to calculate fluids also very accurately. So we either use a burette set, which is a calibrated container, which will tell us exactly how much are we giving. And again, warming fluids using either a volumetric pump or a syringe pump to deliver these fluids. And fluids are treated as medication. So we have to be really very careful about how we do things. And again, it is all about doing it consistently, doing it every day, and practice really does make a man or a woman perfect. Paying attention to the small things, simple things like hypothermia. It wouldn't matter if it is an adult undergoing surgery, but in a child, prevention and practical measures like transporting these neonates in a under an incubator, paying attention to the ambient temperature in the operating room, using a radiant warmer when we are doing procedures, simply wrapping the limbs, conducting warming systems, warming mattresses, and for the larger cases, for the big cases where we are expecting a lot of fluid or blood loss, hotline, which is a machine which warms IV fluids and we can give it quite rapidly too. So small, measures, but they go a long way. On the other side of the spectrum, we are always worried about hypothermia, but sometimes patients do become hyperthermic. Sometimes it could be just an ongoing infective process, but sometimes it could be a dreaded complication which is feared by all, which is malignant hypothermia. Now, malignant hypothermia is actually quite rare, but it is not unheard of. And it is a response to some of the medications which are part of the anesthesia process. So it could be succinylcholine, which we don't use that much, but it could be any of the inhalational agents. And the only antidote to malignant hyperthermia is dantrolene. And I'm very proud to say that SRCC is one of the hospitals in the state, in fact, which has the antidote, the only antidote to treat malignant hyperthermia, that is dantrolene. And we got it through a benevolent donor, and we have been stocking the drug. So when we have patients who have a tendency to malignant hyperthermia, which could be a patient with, say, a proven ryanodine receptor defect, or say a patient with myopathy who's not yet been diagnosed, but could have a tendency to develop malignant hyperthermia, we're at least very sure that we can manage this because we have the antidote. And we have been, in fact, ever since we got the drug, we have got requests from other hospitals, and we have even lent our dantrolene to those hospitals, and we managed to save a couple of patients too. So this is something which needs to be, the message needs to be, it's not that it's unheard of in our parts of the world. It can happen to any patient who's undergoing anesthesia simply because the patient may not be tested or may not have a previous exposure to anesthetic, and you could land up with a fulminant, dangerous situation. And we must have the antidote when we are anesthetizing any child, any patient for that matter. The take home, of course, is temperature monitoring is a must, not only to detect hypothermia, but also to detect hypothermia. So there are some frequently asked questions we often encounter when a patient or a child is going to undergo anesthesia. So parents often ask us, is anesthesia safe? Will anesthesia have any adverse effects on my child's scholastic performance? Because you've heard a lot, they've Googled a lot, they have a lot of anxiety. Sometimes it's just like my child is terrified of needles. Who isn't? And many children have stranger anxiety, especially the preschoolers who've never been separated from their, mother or father, and they are the ones who've got a very heightened sense of stranger anxiety. How will you ensure that my baby is not in pain because my child cannot speak? How will you know that he is not in pain? My child is on the spectrum and he has special needs. How will you manage the perioperative course? So a lot of these questions are going to be answered today by my colleagues during the masterclass. And I also invite any further questions you might have, and we'll be happy to answer them. So I'm just going to take one question here, one of the frequently asked questions about anesthesia and neurotoxicity, because they spoke about the fact that we will be giving medications and what if it does it affect the child's growing brain. So what do we tell our parents? So luckily we have robust evidence and we have human studies. I'm not talking preclinical studies. We have human studies. You can Google PANDA, gas, mask study, and these are multicentric studies which have proven beyond doubt that a single brief anesthetic exposure is safe. And it would be unethical to withhold sedation and anesthesia when necessary. So, say for example, a child has got a cleft palate. Are you going to wait till the child grows up simply because you fear neurotoxicity? You need. So, as pediatricians, as general physicians, as primary physicians who will be, who the parents will approach, you can safely tell the patient, you can confidently tell the family that anesthesia is safe. And the risks and benefits of requiring anesthetics must be weighed against the risks of not treating certain conditions. For example, if unnecessary procedures is something we say, okay, you can wait, it's good to wait because the child has a growing brain. And this is when you want to be avoiding certain medications. But beyond 3 years of age, if the child, say, for example, has a supernumerary digit, the child can wait. But if the child has got a cleft lip, a child has got a cleft palate, a child has got an emergency procedure which needs to be done, or an urgent procedure which needs to be done, it has to be done, and anesthesia is safe. So then there are questions, okay, you're talking about a single brief anesthetic exposure. What about prolonged exposure to anesthesia? Is that safe then? So we have this recent paper, and this has given us a lot of confidence, and also given we can talk to our parents. And this is a study which is done in cardiac anesthesia, no less. So what they did was they studied the impact of cumulative anesthetic agents and sedation in children who are undergoing complex cardiac surgery. And these are, you can imagine, the most vulnerable patients, the youngest patients, and the mean age of these patients was about 18 months. And what this study found, the results of the study was this: they found that the total cumulative exposures, that they actually, you can imagine, a child who's coming for cardiac surgery is also undergoing for some radiological procedure. He's undergoing the cardiac surgery. He may have a prolonged post-operative course in the ICU, where he receives a lot of sedation and other medications during his stay. So they found that the total cumulative exposure to volatile anesthetic agents were not associated with neurodevelopmental impairment in infants with congenital heart disease undergoing various imaging studies and procedures. So that is a robust evidence saying that anesthesia is safe, and you can go ahead and tell your families that necessary surgery should be undertaken. What we have done from our side to ease parental anxiety is we have created a small information and activity book. Dr. Bela has been quite instrumental in helping us out, and our thanks to her. So this is for, it gives out information. It's also a workbook to parents, to the children, so they can actually, during their stay in the hospital, they can do some activities. They can color, they can solve some puzzles, and they also get an idea about what to expect during their hospitalization. So this is what is called the 10N principles of pediatric anesthesia. So I'll close with this. So 10N stands for quality. So basically no fear, which means how you take the patient in, how you allay anxiety for the family, for the patient, normovolemia, normotension, normal heart rate, normoxemia, normocapnia, normonatremia, normoglycemia, normothermia, and no postoperative discomfort. And this is what my department strives to do every day. Again, it is not about only us, it is about teamwork. So role clarity is extremely important. So we are helped by our nurses, we are helped by our technician teams, and our surgeons really understand us and they understand our difficulties. And we always have this very close loop, kind of conversation. We have communications always open, so we know exactly what our roles are and what we expect. So Now, do we have enough specialists in pediatric anesthesia? Do we have enough dedicated children's hospitals? Is the question. And the reality is no, we really don't. So, in closing, what I'll say is that you remember the red flags I talked about as until we get there, until we have enough specialists, until we have enough dedicated children's hospital, which would be an ideal world, what we can do is, patients who are less than 3 years of age, patients who are special kids, children who are syndromic, children who are sick, children who have comorbidities, they should be anesthetized by pediatric anesthetists in pediatric children's hospitals such as ours. So I'll leave you with some do's and don'ts of pediatric anesthesia, the 10 commandments, if you may. So we believe in being forewarned. So a very robust pre-anesthetic checkup. So and we insist that every child who is anesthetized is seen by us ahead of time so that we get enough time to talk to the family, to allay their anxieties, parental communication, how we separate our patients from the family, when we are taking them into the operating theater. And my colleague will be elaborating about that. Checking, double checking, taking care of the small things because small things are really big things. Error prevention is paramount. Having help at hand. So always you will have, when we are anesthetizing, especially difficult cases, we are at least two of us, if not more, having help at hand, preventing and preempting common problems, knowing when to say no, and of course, remaining updated all the time. Thank you for your attention and good evening to you. The chat box or
Thank you so much, ma'am. It was a wonderful lecture, very precise, very succinct, and I'm sure it added a lot of value to our listeners. Next, I will be calling Dr. Priyanka, who's a junior consultant in our anesthesia department. She will be talking about minimizing anxiety and maximizing comfort for our patients. Am I audible? Good afternoon, everyone. I'm Dr. Priyanka Muneshwar, Junior Consultant at NHSRCC Children's Hospital, Mumbai. And my topic today is minimizing anxiety and maximizing comfort. So,
Sorry for the interruption. There was some technical glitch. So, just a disclaimer that all the videos, photos that I'll be showing in this presentation, all the protocols that I'll be discussing in the presentation are from NHSRCC Hospital. Yeah. So, why this topic is important? Sorry, I'm not able to. So, why this topic is important for us? Because several studies have reported that the prevalence of perioperative anxiety in children is around 50 to 80%, which amounts to a huge number. And it has the negative impact on perioperative outcome in terms of increased postoperative pain scores, behavioral effects like enuresis, nightmares, separation anxiety, emergence delirium, prolonged post-op care unit stays, high opioid consumption, abnormal sleep patterns, long-term psychological effects like anxiety, and avoidance of further medical treatments even in adult age. So, what causes this anxiety, perioperative anxiety? It is for the children, it is the fear of the unknown. So they don't know why they are in the hospital, what's going to happen, what is the procedure. So some of the parents, they usually make aware to their children that they are transparent with their children, and some of them are not. So it becomes a challenging issue for us in the case that they get anxiety. Other thing is separation anxiety, which usually starts at 9 months of age and peaks around at 1 to 2 years of age. Anticipation of pain, age-specific concerns, like in adolescents, there is loss of control, awareness. They are very much anxious whether they'll be waking up from anesthesia and mutilation. Preoperative fasting add-ons to this anxiety, and if they are having any previous exposure of anesthesia, sedation, which is somewhat traumatic, it also add-ons to the cause. The risk factors include age. As I said, it's the separation anxiety starts at 9 months and peaks at around 1 to 2 years of age. The temperament of the child. If the child is an introvert and socially in a so it adds on to the anxiety. Previous exposure, prolonged fasting, prolonged hospital stay, and anxious parents as well add on to the issue. So we believe that usually the children of anxious parents are usually also suffer from the same thing as the emotions, the attitudes trickle down to them. Age-specific concerns like 0 to 6 months, this is the time period when parents are more stressed than the child because the child is not old enough to understand, is not old enough to know, to remember noxious events. 6 months to 4 years is the age group where there is maximum separation anxiety. They remember whatever procedures they have undergone, but they are not old enough to understand why this is happening. 4 to 6 years is the age when they mostly understand whatever explanations you are giving to them, and they easily accept separation. But they are concerned with body integrity and surgical mutilation. 6 years to adolescence, this age group, separation is very well tolerated and they are better able to understand explanations. Also, they are able to communicate their fears about awakening during surgery, pain, or not awakening. So, most of the adolescents, they have fear regarding conformity, dignity, and they mostly they fear loss of
अहो
control.
प्रतीक 2 फोन आहेत ना तुमच्याकडे, एका फोनवर चालू करा की.
Can I?
Requesting participants to kindly mute themselves.
So, how do we assess the perioperative anxiety in children? So, pre-anesthesia checkup is the best time for assessment of anxiety, and it helps us formulating a plan. Most of the time, our surgeons or pediatricians do forewarn us regarding patients who might require counseling, who are very anxious and will benefit from a pre-op counseling. There are many assessment scales available in the literature. The most common one used globally is modified Yale preoperative anxiety scale, MyPass, which consists of the following domains, that is activity, vocalization, emotional expressivity, state of apparent arousal, and parental presence. So this again has undergone further modification, and they have shortened it, and they have removed the domain which includes the parents. So what are the interventions that we follow at our institute to reduce this perioperative anxiety? So preoperatively, there is robust counseling of the parents as well as the children, use of child-friendly materials like videos, booklets that we'll be seeing in further course. Intraoperatively, we use distraction methods, pre-medication. Parental presence is something which can be used, but at our institute, we usually don't employ it. And post-operatively, we can give a better analgesia service for them, give comfort position and ad libitum feeding. So, age in pre-anesthesia evaluation, usually we explain the children regarding the procedure according to the age. So those who are amenable to some communication, we explain them how the mask induction will go through, or if they don't want mass induction because some of them might be claustrophobic, for them IV insertion is an option. The key point here is a personalized empathetic communication, use of child-friendly materials like books and videos, which gives us an opportunity to provide information and helps the family prepare for the upcoming surgery. This article, the effect of preoperative, showing them the videos which explains them regarding the anesthesia procedure, helped a lot reducing preoperative anxiety in children between 7 to 12 years of age. So this is the booklet that Nandini ma'am also mentioned in her presentation. So here you can see it is a personalized booklet where you can give it to the child in pre-op area a day before, and it's sort of an activity book which communicates, which explains the procedure, which tells them what disease process is going on, how it is beneficial for them, why they are here, and all those things. It also has an activity section where they can ask the questions, they can see whatever the surrounding, they are better adapted to the surroundings and relieve anxiety. So mask induction, explaining so to aid a comfortable IV insertion, the tools that can be used are Buzzy EMLA. Buzzy is a device which gives cold sensation to distal to the proximal to the IV insertion sites. It's based on the gate theory of pain and minimizes the discomfort during IV insertion. So how a well-counseled child will look like in the So here we can see the child has been explained regarding mask ventilation, and he just has to take deep breaths, and it has been explained that he'll go to sleep. We encourage the child that he should hold the mask himself, so there is no sense of loss of control, and he was very happy with the process. Here we can see with the aid of a toy how we are explaining to the child that how we'll be putting on the pulse socks, and then she is okay to put it on herself. The same thing with the mask. When we showed her that on the doll we are giving oxygen, and then the same thing with her, she was really acceptable of the mask, which usually the child won't do. So this child, this was an operated case of Glenn's, in which we wanted to avoid mask induction with sevoflurane. We wanted to avoid pre-medication with midazolam, considering respiratory depression. We wanted basically an IV in situ. So we had applied EMLA at the puncture site. And the child was really comfortable with her mother, and so we went ahead and put in an IV. One other distraction techniques like play therapy, music therapy, storytelling, virtual reality really helps aiding the transition from the pre-op area to the OR. So here we can see that we are trying to build a rapport with the patient. We are trying to gain the trust of the patient so that he'll be comfortable in the OR. Other distraction techniques like we have toy cars, various games and toys in our pre-op area, which sort of we lure them inside with the help of these things. One of the most important thing is letting them be in their tone. So like this child, he was looking at the videos in the pre-op area, and we just let him see that, watch that thing, whatever is familiar to him, and took him inside the OR. So what if these distraction techniques, all this counseling is not helping? What will we do in that scenario? So what usually we go for pre-medication. So this is the review article written by Nandini ma'am, which beautifully explains the process of induction and pre-medication of anesthesia in pediatric patients. So again, in the same article, this table is given which gives all the doses and routes on different drugs that we usually use as pre-medicants. The most common pre-medication that we use is usually either oral midazolam or intranasal midazolam, depending on how much ever time we have have in the pre-op area. So intranasal midazolam 0.3 mg per kg, it usually calms down the patient, and the patient is pre-medicated in 10 to 20 minutes of time period. Other commonly used drugs are alpha agonist, clonidine, and dexmedetomidine. So usually the pre-medication is planned according to the OT timing. It is important to explain the parents regarding the effect of the drug, considering that they will be there to see they are not used to the fact that the child is getting sedated in front of them, is losing control in front of them. As also with regards to midazolam, there might be a paradoxical reaction, which itself is very noxious thing. There is the need to assess of double pre-med as well. So whenever the child with special need or a child with autism, ADHD, we usually employ double pre-medication, which is usually given in the ward 1 hour prior to procedure. Drugs that are commonly used for double pre-med are either clonidine 3 mg per kg or nasal dexmedetomidine 1 to 2 mg per kg, followed by midazolam either oral or intranasal in the pre-op area. So what an effective pre-medication looks like. So here we can see the child has received nasal pre-medication, and after 10 to 15 minutes, we have taken the child in the OR and is readily accepting the mask without any retaliation. Parental presence of induction is one of the methods through which we can induce the patient, but it requires a good setup and proper selection of patients is required, because we need a calm and composed parent for this process. As also the anesthesia providers should be comfortable with the process. Then only we should go ahead with this parental presence induction. Post-op analgesia is an important part of allaying anxiety. At our institute, we usually employ multimodal analgesia with regional anesthesia and IV painkillers. Regarding this, Dr. Vedhika will be talking in subsequent presentation. One more important thing which adds on to the anxiety is preoperative fasting. So following proper orders according to age and OT timings is very important. Adherence to, because it also helps us in adherence to OT schedule and avoid prolonged fasting. So this has been, we are trying to start this initiative where we are we are putting these sheets on the bedside of the patient, where the timing of the surgery is mentioned, and it has provision of letting the parents know, letting the nurses know how we have to follow the fasting. This article, Enhanced Recovery After Surgery in Pediatrics, it is a review article, and it explains, it mentions early ad libitum feeding with regards to post-op feeding. So they say that early, as there are no such guidelines when to start feeding after the procedure. So whenever the child is fully awake, we should start feeding. Ad libitum means it is a free feeding thing. So whenever child is asking, whatever the child is asking, we should give instead of protocolized feeding. Special note regarding the special kids. This group includes autism spectrum, ADHD, CP childs. These childs who are not amenable to counseling and are almost always need pre-medication as well as double pre-medication sometimes. And they are preferably scheduled as first case of the day. So to summarize, it is very important to assess the anxiety. Pre-operative preparation assessment is very important. Inclusion of the parents or family really helps reducing the anxiety of the child, and individualizing the plan according to the temperament of the child, according to the need of the child is important. And our aim is always to deliver a superior, holistic, and safe pediatric perioperative care. So all we need is a happy child for a safe and happy outcome. Here we can see that this is a liver transplant recipient along with his mother, and we were just trying to alleviate anxiety of mother as well, doing this as well as the child. Thank you for your kind attention. Any query, you can put it in the chat box.
Thank you so much, Priyanka. The lecture was truly wonderful and very, very visually appealing also, I must say. So next we have Dr. Sridivya. She is our fellow in Pediatric Anesthesia. She is going to be talking about anesthesia for hip surgery in children, a new paradigm.
Good afternoon, all. I'm Dr. Sridivya, Fellow in Pediatric Anesthesia at SRCC Children's Hospital, Mumbai. I'll be speaking about analgesia for hip surgeries in children. Common hip disorders in the pediatric population coming for surgery can be broadly divided into three categories based on the age of the child. Age 0 to 4 present commonly with developmental dysplasia of hip, where there is abnormal development leading to subluxation or dislocation of hip joint. They commonly come for open reduction of hip joints. Age 4 to 10 present with Perthes disease, where there is idiopathic avascular necrosis of proximal femoral epiphysis. Age 10 to 16 present with subcapital femoral epiphysis displacement, and these two patients come for femoral osteotomies. The signs and symptoms of various pediatric hip disorders often tend to overlap. Postoperative pain due to hip repair surgeries in children is a major cause of concern, and multimodal analgesia is the preferred method of pain management for hip surgeries in children. This regime commonly includes a combination of various drugs with different modes and sites of action. It includes administration of drugs such as acetaminophen, NSAIDs, alpha-2 agonists, NMDA receptor antagonists, and administration of local anesthetics in terms of either central nerve axle blockade or peripheral nerve blockade. This has been proven to reduce opioid usage, improve pain control, accelerate the recovery process, and in turn reduce the hospital stay of children. The most frequently used regional methods in children are central neuraxial blocks, that is caudal or epidural blocks. Caudal blocks have been easier to get familiarized with and have been widely used to provide analgesia in the pediatric population. However, Central neuraxial blocks result in various effects, including bilateral sensory and motor blockade, sympathetic blockade with its associated hemodynamic effects such as hypotension, shorter duration of analgesia, urinary retention requiring post-op urinary catheterization, prolonging the hospital stay of the child. So the lumbar plexus block is a peripheral nerve block that can be given for the surgeries involving hip and proximal femur in the children. So it was first described in the year 1976 by Cheyenne et al. It was described as a posterior lumbar plexus block or a psoas compartment block, where the whole of the lumbar plexus was blocked with a single injection. Since the initial description of this posterior lumbar plexus block, a number of variations of this technique have been described. However, most of these differ from the original technique in only minor detail. The original technique relied on a feel of loss of resistance, which is encountered on passing the needle through the fascia of psoas. Its use decreased over time due to technique's complexity and potential for complications such as intraneural drug spread, damage to the abdominal viscera, and hematomas. However, with advent of ultrasonography and nerve stimulator techniques, this block can be safely performed in this population. Before going ahead with how we went ahead with the block, let's just briefly go through the anatomy of lumbar plexus. Lumbar plexus is a web of nerve roots that is located within the psoas muscle compartment. It is formed by the ventral rami of L1, L2, L3, and L4. These nerve roots merge to form a plexus that lie just lateral to the lumbar vertebrae within the substance of the psoas major muscle. The individual branches then emerge from the psoas major muscle and innervate the respective targets in the anterior thigh. So we can see the end branches, that is iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, lateral femoral cutaneous nerve, femoral nerve, and obturator nerve. These nerves supply the motor and sensory innervation to the lower limb and pelvic girdle. European Society of Regional Anesthesia describes this in the category of deep blocks, and it is also considered as an advanced regional anesthesia technique. How we went ahead with the block procedure? After taking the written informed consent from the parents, we went ahead with giving the general anesthesia as per our standard institute protocol with fentanyl 2 microgram per kg and propofol 3 milligram per kg. We avoided administration of muscle relaxant to avoid any interference with the nerve stimulator technique that we were going to use. After administration of general anesthesia, we positioned our patients in the lateral decubitus position with the hips flexed and the operative side facing upwards. A small shoulder roll or the gel support was placed underneath the dependent flank, after which we performed the block with a linear or a hockey stick probe. The probe was first placed in the transverse orientation in the mid-axillary line, just above the iliac crest, and shamrock-shaped image was identified. The needle was then inserted perpendicular to the skin. After inserting the needle into the skin, we switched the peripheral nerve stimulator machine that we had and set the current intensity at 1.5 milliampere. After which, we advanced the needle till we obtained the desired motor response, which in our case was the quadriceps muscle twitch. The stimulating intensity was gradually reduced to 0.5 milliampere while maintaining this response. This is how we positioned our patient. This is the lateral decubitus position. And we placed the shoulder rolls underneath the dependent flank, which helps in expanding the space between the non-dependent 12th rib and the iliac crest. And this is how we place the probe in the mid-axillary line, just above the iliac crest. After placing the probe, we obtained a sonographic image somewhat like this. So this is a small video along with pictorial representation of the same for better understanding. So here we can see the anatomical arrangement of three muscles around the lumbar transverse process. We can see the psoas major that is lying anterior to the transverse process, erectus spinae muscle lying posterior to the lumbar transverse process, and the quadratus lumborum lying at the apex of the transverse process. These three muscles produce a sonographic pattern of a shamrock that has been likened to the image of a shamrock with the three muscles representing its three leaves. So here we can see the lumbar transverse process with a small hyperechoic region within the substance of the psoas major muscle, which is our target. Here we can see the needle trajectory and how the lumbar plexus is surrounded with our drug. All the blocks we performed were under dual guidance and were single shot blocks using 0.5 ml per kg of volume of 0.25% bupivacaine and clonidine 1 microgram per kg. Assessment of efficacy of the block was done in terms of intraoperative consumption of fentanyl and time to first rescue analgesia post-operatively with tramadol 1 milligram per kg. Post-operative analgesia was assessed with face, leg, activity, cry, and consolability scale, that is the FLAC scale, for children under 7 years of age, and visual analog score, that is VAS score, for children more than 7 years of age. As a part of multimodal analgesia, we gave paracetamol 15 milligram per kg and diclofenac 1 milligram per kg in all our cases. So we performed this block in about 12 cases at our institute, and this was our experience. So we gave the block between in age group 1 to 15 years, and most of the patients came for femoral osteotomies and already operated case of femoral osteotomies for implant removals and for open reduction of hip joint. So we can see that in one case we needed administration of rescue analgesia right at the time of incision, and we considered that as a failed action of the block. And in 2 cases, we had to give rescue analgesia post-operative. So of the 12 blocks that we performed, 9 were deemed adequate, while 1 had an inadequate action requiring rescue analgesia at the time of incision. 2 needed rescue analgesia post-operatively. In one case, we had to supplement with sacral plexus block as well, as the surgery involved periacetabular osteotomy with femoral osteotomy. The average time taken to perform the block was between 8 to 14 minutes, and the average duration of analgesia was between 12 to 16 hours. And in our experience over 12 cases, there were no complications observed. In conclusion, our experience highlights the safety and efficacy of the lumbar plexus block under dual guidance as a suitable alternative to the epidural block for children undergoing hip surgeries and lower limb osteotomies. Lumbar plexus blocks offers distinct advantages such as better hemodynamic stability, no urinary retention, and early mobilization over epidural blocks. It can also be offered as a safe analgesic option in cases where central neuraxial blockade is contraindicated. These are my references, and thank you for your patient listening.
Thank you, Dr. Sridivya, for that very nice presentation. Our fellows have all been doing very well. We started the fellowship course in 2020, and this is our 4th batch of fellows. And I'm extremely proud and happy to state that they have all been well placed after finishing their fellowship at SRCC. Some of them have joined our team, and the others are also in reputed hospitals such as AIMS and other places. Thank you. Next, I introduce Dr. Naveed Khan. She is an extremely valuable member of our team, a pediatric cardiac anesthetist, and she will be talking to you about the scope of pediatric cardiac anesthesia, giving you an idea about what they do when they're anesthetizing small children. So over to Dr. Naveed.
Thank you for that introduction, ma'am. So I'm Dr. Naveed. I'm a consultant anesthesiologist at SRCC Children's Hospital. I specialize in pediatric cardiac anesthesia, and my topic is rightly named Tiny Heart, Big Challenges. So the subspecialty of pediatric cardiac anesthesia began in concert with the early history of congenital heart surgery. It is actually almost impossible to talk about pediatric cardiac anesthesia without talking about surgical correction of congenital heart diseases. So it all started in 1938 when Dr. Robert Edward Gross ligated the patent ductus arteriosus of a patient. The patient was a 7-year-old girl, and the surgery took place at Boston Children's Hospital. And this is the day, I think, where the specialties of cardiac surgery, pediatric cardiology, and pediatric cardiac anesthesia were born. In November 1944, Dr. Alfred Blalock first performed the Blalock-Taussig shunt. This was in a 15-month-old girl, which was she was a case of tetralogy of Fallot, and it was done at Johns Hopkins Medical Center. This is when people started looking towards palliating cyanotic heart diseases. Before that, we had no treatment for palliation of cyanotic heart diseases. The first successful surgical repair of coarctation of aorta was performed by Dr. Clarence Crawford in 1944 at Sweden, Stockholm. And the patient was a 3-year-old boy who underwent an end-to-end resection of the coarctation and anastomosis. So while all of these surgeries were very landmark in their own right, but they were all extra cardiac, and we still had no way to perform an intracardiac repair. So the game changer was when in 1953, Dr. John H. Gibbon Jr. developed the first successful heart-lung machine. We call this machine as the cardiopulmonary bypass machine, and the first patient that he operated using this machine was an 18-year-old male with atrial septal defect. And then this is when the specialties of cardiac sciences actually took off. And also, anesthesia challenges multiplied rapidly in association with cardiopulmonary bypass, coupled with early attempts at complete intracardiac repair. With advances in cardiac surgery and cardiology in the last 6 to 7 decades, pediatric cardiac anesthesia also has experienced significant evolution and growth and emerged as a distinct field requiring specialized training. So what is prevalence of congenital heart disease? This is the most frequently occurring congenital disorder. 28% of all congenital birth defects are congenital heart diseases, and the birth prevalence of CHD is reported to be around 8 to 12 per 1,000 live births. So that means about 1.35 million babies are born with congenital heart disease each year globally. 1/5 of these babies have critical heart disease, which requires very early intervention. And if early screening and diagnosis and treatment is available for these children, over 90% of them will survive to adult life with long good-term outcome. So what are the patient population that we deal with? We deal with preterm neonates as well as adult congenital heart disease patients. We also call them as GUTs, which is grown-up congenital hearts. So as far as preterm neonates are concerned, the previous strategy was one of initial palliation followed by complete repair in childhood. But as the cardiac sciences field has progressed, the current strategy is to do a complete repair within days to week of birth. Why are these patients different? Because their physiology is different. So when we talk about preterm neurology, we know that they have a metabolically more active brain with a disrupted cerebral autoregulation. A coexisting congenital heart disease results in either reduced cerebral blood flow, reduced cerebral oxygenation, or both. This makes the preterm neonatal brain very much more prone for brain injury. Coming to the pulmonary system, they have small size of trachea and airways with a higher resistance to flow, increased tracheal compliance, poorly developed accessory muscles of respiration, and reduced functional residual capacity. All of these cause them to have pulmonary edema very easily. Coming to the neonatal heart. Neonatal heart is very much less compliant as compared to the adult heart. It has a high oxygen demand. Also, it has to fulfill the increased cardiac output requirements of the rest of the body. This is what makes the neonatal heart more prone for bradycardia as well as heart failure. The hepatic and renal systems are not very well developed because of the organ immaturity. There is reduced protein synthesis and glomerular filtration. Also, preterm neonates frequently have respiratory distress syndrome, necrotizing enterocolitis, and intraventricular hemorrhage. These conditions are even more difficult to manage in a premature newborn who has a coexisting congenital heart disease. Conversely, the early repair of specific cardiac defects are also prevented by complications of prematurity. Coming to teenage and adult patients with congenital heart disease, they pose their own risk. Now, because of the advances in cardiac sciences, over 85% of infants born with congenital heart disease are expected to reach adulthood. So these patients, as they become adults, they have some problems which accrue with aging, which really the doctors who are looking after them all this while cannot handle. Also, because of their congenital heart defects, they have been living with this congenital heart disease, either repaired or unrepaired, and they pose problems which pediatricians are not able to manage. So, what are the non-cardiac sequelae of long-standing congenital heart disease? When we talk about the pulmonary system, there is increased pulmonary blood flow or obstruction to free pulmonary venous drainage, both of which cause increase in interstitial fluid. There is decreased pulmonary compliance, increased work of breathing. And as we know, the most serious complication of long-standing pulmonary hyperemia is the development of Eisenmenger physiology. Coming to the hematologic system, this is predominantly a consequence of long-standing cyanotic congenital heart disease. And they are more prone for bleeding because of abnormalities of red cell regulation, hemostasis. Also, there is increased tissue vascularity due to elevated systemic venous pressure and abnormal aortopulmonary and transpleural collateral vessels. Again, a lot of these patients come for redo surgeries. They redo surgeries may be due to because they are the next surgery of a planned stage procedures. Like a lot of our single ventricle patients have to undergo almost 2 or 3 surgeries in a planned manner. So they are almost always coming for a redo surgery. Also, even if it is not a single ventricle patient, the surgery might be for some sequelae or residual lesions or complications of previous surgeries. So redo procedures, of course, have increased morbidity and mortality as compared to non-redo surgeries. They also have abnormal renal histopathology due to chronic cyanosis. They have hypercellular glomeruli with basement membrane thickening, focal interstitial fibrosis, tubular atrophy, hyalinization of afferent and efferent arterioles, and high plasma uric acid levels. Coming to the neurologic system, adults with unmodified or persistent intracardiac shunts remain at risk for paradoxical emboli. Cyanotic adults remain at risk for development of brain abscesses, and a healed childhood brain abscess can also serve as a nidus for seizures throughout adulthood. So this is a table, these are two tables showing the residua after reparative heart surgery and the sequelae after reparative heart surgery. So residua is something which has not been totally corrected even after a surgical correction. So for example, there are some heart diseases like congenitally corrected transposition of great arteries, which are very, very prone for arrhythmias. So that electrophysiological abnormality remains even after doing a complete repair. Some valvular problems like incontinence of the valve or stenosis of the valve also remain. The changes that have happened in the ventricle chamber morphology or the chamber mass and function, they also sometimes remain after complete repair. There might be many non-cardiovascular residua also, like developmental abnormalities, mental retardation, physical retardation, and somatic abnormalities, central nervous system abnormalities like seizures and focal neurological defects, and other visual and auditory abnormalities. So sequelae are something that, as the table 2 shows, that happen after cardiac surgery, and that is to be expected. Some surgical maneuvers come with some sequelae. Like for example, if there is an incision on the atrium or the ventricles, which is called as an atriotomy or a ventriculotomy. So these sites are always sites from where arrhythmias can occur. And if a valve has been operated on, so in the future, they can always have left ventricular or right ventricular outflow tract problems. Prosthetic materials, which are very frequently used, like patches, valves, and conduits, they undergo calcification and they cause further cyanosis, which we need to, these patients usually come for a conduit change or a valve change. Also, the other than preterm neonates and grown-up congenital heart disease patients, the other patients with a lot of morbidity that we very frequently deal with are syndromic patients. So as we know, there are a few genetic syndromes which are associated with cardiac abnormalities. And not only are these syndromes associated, they are associated with some specific cardiac abnormalities. Like for example, Down syndrome, we usually see ASDs, VSDs, AV septal defects, and tautology of Fallot. Like Turner's patients usually have coarctations, bicuspid aortic valves, aortic stenosis, and HLHS. So they have added morbidity and mortality not only because of their genetic syndromes and their multi-system involvement, but to give you an example, if we have a 3-year-old with a large VSD, if we compare two children, one who has a Down syndrome and one who doesn't have Down syndrome, we will see that the Down syndrome patient may have a higher level of pulmonary artery hypertension, may become inoperable much earlier than the non-syndromic patient. So now I'm going to be talking about the scope of pediatric cardiac anesthesia. What we usually do in our day-to-day practice is we start from the preoperative evaluation and optimization of children who are posted for cardiac procedures. We give anesthesia for cardiac surgery, including minimally invasive procedures, catheter-based interventions, and hybrid procedures. Sedation and anesthesia for a cardiac patient undergoing radiological imaging. Providing anesthesia and critical care support for children in the cardiac intensive care unit preoperatively as well as postoperatively. Implementing comprehensive pain management strategies in cardiac patients by using multimodal pain management techniques. And participating in medical research, teaching, and mentoring medical students, residents, and fellows. What does a preoperative evaluation consist of? We take a detailed medical history and physical examination, all routine lab investigations, chest x-rays, echocardiographies, if required USG, CTs, and MRIs. We look after the optimization of ongoing cardiac medications and treatment of concurrent upper respiratory tract infections. Coming to the cardiac OT, so we have many distinct types of congenital heart diseases, ranging from simple to complex to critical malformations. So some defects that we see very commonly in infancy include ventricular septal defects, tetralogy of Fallot, transposition of great arteries, coarctation of aorta, and atrioventricular septal defects. So of all the patients that come for cardiac surgery, we have a risk stratification system in place. So the risk stratification system that we use is the RAC score, wherein we go from category 1 to category 6 in increasing levels of complexity. So for example, category 1 patients have a PDA or an ostium secundum ASD or a sinus venosus kind of ASD and aortic coarctation, right up to category 5, wherein we have truncus and interrupted arches, Ebstein's anomalies, and category 6 in which we have Norwood surgeries. So obviously the morbidity and the mortality increases as the RAC score increases. After the patient has been taken inside the OR, we start with the monitoring. So we have monitoring of all systems like cardiac, including vascular access, wherein we put the arterial line and the central venous pressure lines. Also, sometimes for some cases we have the surgeons putting in the pulmonary artery pressure lines and the left atrium pressure lines, PAPs and LAPs. We also do a lot of intraoperative echocardiography, which can be transesophageal as well as epicardial. Respiratory system is monitored via ventilatory parameters and frequent arterial blood gases. Neurologic system are monitored for some cases like arch repairs, wherein we use a BIS monitor or the nurse monitor. And coagulation parameters are frequently monitored via ACT and TEG machines. So we not only monitor the patients and induce and maintain adequate analgesia and anesthesia, but we also work with the surgical and perfusion team to manage extracorporeal circulation, deep hypothermia, and circulatory arrest. We also take care for preservation of vital organ function, management of post-bypass myocardial dysfunction, coagulation, and transfusion. Coming to the cardiac intensive care unit, herein we manage the preoperatively critically ill child, post-operative cardiac dysfunction by means of pharmacologic like inotropes as well as mechanical support, that is ECMO machines. Post-operative respiratory dysfunction by optimum ventilation strategies. Postoperative renal, gastrointestinal, hepatic, and neurologic dysfunction, as well as postoperative pain management by using multimodal techniques. This is a photograph of our ECMO machine. We have 3 such machines, and this was our patient, a recent patient who we had on ECMO for a period of about 3 to 4 days. Coming to the catheterization lab. So a lot of pediatric procedures are undertaken in the cath lab. The diagnostic procedures are done to refine complete anatomy where echo windows were poor. We assess pulmonary artery pressures so as to plan suitability for surgery. We assess the feasibility and plan intervention procedures. Also, we do diagnostic procedures to assess pulmonary artery anatomy, pulmonary artery pressures, and aortopulmonary collaterals. Diagnostic procedures are also done in some post-operative patients, example post-PA banding and post-Glenn shunt, to decide about the next stage in the surgery. The interventional procedures that we undertake in the cath lab include septal defect device closure of systemic to pulmonary shunts, atrial septostomies, valvuloplasties, angioplasties, and placement of stents. The challenges in the cath lab usually include remote location. That means the location is far from the OT. The ergonomics of the place, that means there are a lot of moving parts, a lot of wires, positioning, and limited access to the patient. And we manage complications like bleeding, arrhythmias, hypotension, and coronary ischemia. Coming to the radiology suite, this is a photograph of our CT and MRI suite. There are different challenges during MRI for infants and small children. This include limited access to patient and equipment, low ambient temperature with risk of hypothermia, a noisy, unfamiliar environment, and remote location from the operating room. Over and above this, challenges for cardiac MRI and CTR, these children have faster heart rates, and a significant number of patients have very poor cardiac results. We have to give some medications to them to reduce their heart rate so that the imaging is done in an optimal manner. And acute resuscitation in the event of sudden cardiorespiratory deterioration is difficult, as these patients need to be withdrawn from the MRI room. Talking about the congenital heart disease burden in India, so vast majority of children born in high-income countries reach adulthood. But this is not the case with low and middle-income countries like India. Considering a birth prevalence of 9 out of 1,000, the estimated number of children born with CHD every year in India approximates to 240,000. And because we do not have universal pediatric cardiac care for this high number of children with CHDs, approximately 10% of infant mortality in India may be accounted for by congenital heart diseases. This is an article by Dr. Krishna Iyer, pediatric cardiac surgeon, wherein sir has mentioned the projected manpower requirements to provide universal pediatric cardiac care. As we can see, where we stand with the current numbers and the required numbers, there's a huge discrepancy, not only in the personnel, like anesthesiologists, intensivists, nurses, cardiac surgeons, cardiologists, and perfusion, but also in the number of centers that is required to provide universal pediatric cardiac care in India. At SRCC, wherein we have a very robust cardiac science team, we have had the privilege of doing in the last 5 years around 3,501 cardiac cases and still counting. We've done 1,637 cath cases. The RACS distribution of our cases, we mostly have RACS 2 cases and a fair amount of RACS 3 cases also. Our mortality stands somewhere at 3.3%. A huge way to go. The developed world has a mortality of somewhere around 2%. And last but not the least, I would like to tell that pediatric cardiac care thrives on teamwork. Actually, it's impossible for pediatric cardiac sciences to work without a team. And the cohesiveness of the team of caregivers has a strong and direct impact on patient outcomes and efficiency of the system. We're very lucky to have a very good pediatric heart program. So this, as we can see in this chart, the pediatric cardiology team manages the echo, the MRI, or the other non-invasive imaging. They do cardiac catheterizations and interventions. They look after the electrophysiology. The pediatric cardiac surgery team, which includes the pediatric cardiac surgeons, the anesthetists, the perfusion technologists, and other support personnel. And then we have the intensive care team, which includes the above two teams, as well as the infection control, nursing, respiratory therapy, and intensive care team. So this is a part of our ICU team, our physiotherapy team, our clinical nutrition team, our perfusion team, our anesthesia team, and our cardiac team. Thank you very much for your kind patience.
मैसेज देना पड़ेगा ना।
So next we have Dr. Dixita Shetty. She is one of our fellows. She's going to be talking about the neonate with a complete heart block, ensuring a safe passage. So I welcome Dr. Dixita.
Thank you so much, ma'am. So, good evening, all of you. I am Dr. Dixita Shetty, Fellow of Pediatric Anesthesiology in SRCC Hospital, Mumbai. So, my topic today is a case of neonatal congenital complete heart block. So, talking about the topic, atrioventricular block is a disturbance of cardiac conduction with abnormal propagation of the electrical impulse due to structural or functional abnormality. The incidence of these blocks are 1 in 15,000 to 22,000 live births. The most prevalent form of this congenital AV block is autoimmune. In most cases, mothers are diagnosed with SLE or Sjögren's syndrome with increased levels of anti-RO, SSA, and SSB antibodies, which are believed to be the most important risk factors. The clinical manifestations in fetus will be bradycardia with heart rates of less than 100 beats per minute, pericardial effusion, ventricular dilatation, and reduced ventricular contractility. As there is no effective prophylactic treatment for this, and as this block is complete and medically irreversible, permanent pacemaker implantation is only the definitive treatment. But although as the studies are going on, few medical treatment has also been tried. So how we monitor these patients as mother part and fetal part. So maternal monitoring includes the disease activity of the mother, and few drugs which is compatible with pregnancy are prednisolone, cyclosporine, tacrolimus, which are being tried. And once the diagnosis has been done, fetal echo is done 16 weeks onwards. There can be two things. One thing can be a complete heart block in the baby, and second thing can be inflammatory thing which is going on because of this autoimmune disease causing pleural and pericardial effusion. So dexamethasone and betamethasone are tried in fetuses. And due to increased risk of preterm birth in these cases, cesarean delivery is preferred in mother. Now coming for the diagnosis, so fetal echocardiography remains the gold standard for diagnosis of congenital AV block. After birth, fetal bradycardia can initially be controlled by drugs such as isoprenaline, atropine, ephedrine, epinephrine, dopamine alone, or in combination with transcute pacing and temporary cardiac pacing to prevent cardiogenic shock and sudden death of the baby. The outcome of the pregnancies in women with Sjögren's or SLE with fetal congenital AV block can be excellent with use of multidisciplinary management approach involving an obstetrician who specializes in high-risk pregnancies, rheumatologist, neonatologist, pediatric cardiologist, cardiac anesthesiologist, and availability of an ICU care in a tertiary pediatric hospital. So coming to the case, a 32-year-old gravida female with gestational age of 33 weeks and her obstetric score was G4P3L2A1 with anti-RO positive Sjögren's syndrome was admitted in the hospital. Her fetal echo of 30 weeks gestational age was suggestive of congenital complete AV block with ventricular rate of 52 beats per minute. But the structure of the heart was normal with normal biventricular function. Her obstetric scan of 1 week prior to admission showed live intrauterine gestation of average 32 weeks 1 day, and there was evidence of fetoplacental insufficiency with heart rate of fetus 51 beats per minute with effective weight of 1.9 kilograms. Here is a picture showing symptoms of connective tissue disorder in mother. It includes dry eyes or itchy eyes, vaginal dryness, dry nose and frequent nosebleeds, dry mouth, mouth sores or thickened spit, dry skin, dry throat, including coughing frequently. So, talking about the gestation mother admitted in a hospital, mother was vitally stable and so was taken for LSCS, that is elective lower section cesarean section, in presence of a team of neonatologist, anesthesiologist, and cardiologist. After birth, baby required bag and mask ventilation for 30 seconds.
Once the baby started crying, the baby was put on nasal prongs and shifted to neonatal intensive care unit. Weight of the baby was 1.8 kgs and Apgar score reported at 1, 5 and 10 minutes was 5, 8 and 8. And as mentioned before, that there is a medical treatment followed or given to the baby because the prevention of sudden death of the baby and cardiogenic shock. So as the heart rate of the baby was around 50 to 55, our baby was put on dobutamine and isoprenaline infusion. And baby was monitored in neonatal intensive care unit. There the baby got shifted to high frequency nasal cannula due to the respiratory distress. And later, serial ABGs were done, which was suggestive of metabolic acidosis because of inadequate cardiac output. So later on, the baby got intubated and an emergency decision for a temporary pacemaker was taken at midnight. The procedure was planned in cardiac catheterization lab under general anesthesia. Now coming to the challenges faced for this case. First one was place-related challenges, second patient-related, and third surgery-related. So talking about the space, as the procedure was planned in cardiac catheterization lab, it is an out of operating room procedure. So all the complications related to non-operating room anesthesia came into the picture. It was lack of access and space due to heavy machinery. Temperature control was inadequate. And as our baby was preterm, so patient-related complications were hypothermia, hypoglycemia, hypocalcemia, immature organ systems, which can affect the slow drug metabolism given for anesthesia, and also difficult intravenous and transvenous access for the baby. And the surgery-related complications were small vasculature of the preterm baby, small anatomy, bradycardia, which was there in the patient, which can lead to hypotension or collapse anytime, arrhythmias while inserting pacing wires via the cardiologist, and cardiac arrest. So keeping all these challenges in mind, we had prepared our case. So preoperatively, we have prepared ASA, all standard ASA monitors were kept ready with defibrillation pack. Emergency inotropic drugs and infusions were aspirated with long tubings because of the lack of space in cardiac catheterization lab. Airway tray with appropriately sized equipments were ready for the preterm baby. Intraoperatively, as baby was already intubated in neonatal intensive care unit, here baby was transferred via bag mask ventilation and induced with injection ketamine 2 milligrams per kg. Talking about maintenance of anesthesia, it was maintained on oxygen, air, sevoflurane on controlled mechanical ventilation on pressure control mode. Normothermia was achieved by fluid warmer and warm betadine pails. Post-operatively, as the procedure went uneventful, the baby was shifted to neonatal intensive care unit, intubated, and was extubated the next morning. A high-frequency nasal cannula trial was given for a day, and after that, there was no requirement of oxygen. Was extubated the next morning, and high-frequency nasal cannula trial was given for a day. After that, there was no requirement of oxygen, and even RT feedings could be started for the baby. And the baby was serially monitored with ABGs and all other monitors in neonatal intensive care unit. So as the baby was doing well, on day 5, baby was planned for permanent pacemaker under general anesthesia. Now, all the challenges mentioned before came into the picture again, along with additional challenges that was of blood loss, because creating a pocket for keeping the device was an invasive procedure. So there was an expected blood loss for the baby, and also the availability of corresponding size of the pacemaker for a neonate was a challenge. So the baby was taken in operation theater. Baby was pre-oxygenated and induced with ketamine 2 milligram per kg. Injection cisatracurium 0.2 mg per kg was given, and patient was intubated with 3 uncuffed tubes. Anesthesia was maintained on oxygen, sevoflurane, and air. And again, the surgery was uneventful with permanent epicardial pacing wires inserted into the baby. Here are the pictures shown of the device as as you can see that the size of the pocket, the size of the device is huge, so that it is a challenge for the surgeon to create such a large pocket due to expected blood loss. So here I conclude, and the reason why I selected this topic, because it showed how we took a case of maternal connective tissue disorder, okay, and then from maternal care to a baby which was monitored after putting infusions, which was required to prevent the sudden death. Then we took a right call to take the baby for emergency pacemaking at night, midnight, and also once the baby was doing well, we shifted the baby to for a permanent pacemaker procedure. So it was a well-managed case. Okay, so the main thing of conclusion is that multidisciplinary team approach in a tertiary care hospital is essential for providing such a comprehensive care and successful management of such high-risk pregnancies and newborns. Thank you so much.
Thank you so much, Dr. Dixita. That was a very well-managed case. Next, I would like to present Dr. Lopamudra Majhi, Consultant Cardiac Anesthesiology. Lopa is going to be talking about a very challenging cardiac case.
Thank you, Naveed. Good evening, all. Naveed has already described about the scope of cardiac anesthesia, and I'm going to talk about one of the challenging cardiac case, what we managed here, and why it is challenging. As we discuss the case, we will come to know. So the 10-day, coming to the history, 10-day-old male presented clinically with respiratory distress since birth, and the baby was born at 25 weeks of gestation, and it out of emergency LSCA due to premature rupture of membrane. The baby required surfactant therapy and an IV ventilation in the OR itself and shifted to the NICU. But still, patient had persistent respiratory distress and requiring mechanical ventilation. So did echo. On echo, they found there was hemodynamically significant PDA, which is causing congestive cardiac failure and giving rise to pulmonary edema sort of picture. So patient eventually got intubated, and finally patient transferred to our hospital for PDA surgical ligation because they tried medically close that PDA, but it was not successful. So patient got transferred to our hospital. So once we got the patient, when we do our pre-anesthesia assessment, we found baby was weighing 670 grams, and lengthwise he was only 29 centimeter. Heart rate was 168 per minute. Sinus rhythm, BP was 60 by 24 millimeter of mercury with 0.1 mics per kg per minute adrenaline support. Peripheral pulsations are well felt. Respiratory rate was 56 per minute, saturating 92% with 40% of FiO2, and your AF was at level. So on CNS examination, systemic examination, baby was moderately active with ETT in place. Patient was getting ventilated in PC-AC mode with IE ratio of 1:1.5, FiO2 40%, PEEP of 5. On auscultation, there was bilateral conducted sound and bilateral inspiratory crepitations are present. On CVS examination, there was hyperactive precordial pulsations. S1, S2 was normal, and there was a grade 3/6 continuous murmur at the left lower sternal border. So we sent all the lab investigations on lab results. There was neutropenia, thrombocytopenia, CRP was 77, suggestive of infection. Other investigations are normal. On chest X-ray, there was bilateral lung infiltrates and suggestive of pneumonia. And on abdominal X-ray, there was hepatomegaly and there is gastric dilatation. We did echo to confirm the diagnosis again. There was 4 millimeter of PDA, which was shunting left to right with dilatation of the left atrium and left ventricle, which suggested that there is left heart volume overload. So what plan was whether we should do it in the OT or we should do that thing inside the NICU. So while transferring such sick neonate, there are a lot of complications like cardiorespiratory instability, there is thermal dysregulation, there may be accidental endotracheal tube dislodgement, displacement of invasive lines, infusion pumps may give rise to dysfunction leading to purge of inotropes or discontinuation, and that may be while shifting the patient incubator malfunction. So with discussion, we planned the surgical ligation of the PDA inside in NICU. So when we planned it in NICU, so what anesthetic challenges we are going to face? It may be patient related, it may be because of the place related. So patient related, patient is extremely premature, very low birth weight, patient was having immature lungs, there was neonatal sepsis. Work related, there is very limited workspace shared with both the surgical team and the neonatologist. There is restricted anesthesia equipment. We need meticulous monitoring of hemodynamics, particularly the respiratory status, without anesthesia machine actually. So there is, when we are doing PDA, ligation needs lot of blood pressure control due to frequent changes in circulations. As the baby is very tiny, so there is difficulty while putting the invasive lines and need to prevent the hypothermia, and of course most important is maintaining the optimal sterile condition inside the NICU when we are doing in NICU. So keeping all these things, so how we prepared? So initially we kept the baby NBM for 6 hours prior to surgery. With the NBM, we started 4 ml per kg per hour of 10% dextrose with half normal saline. Before that, and we set the NICU ambient temperature to 28 degrees. We kept that overhead lights on, radiant warmer was fixed to manual mode at 35 degrees centigrade. We put 3 lead continuous ECGs, both core and peripheral temperature probes have been put, and we took both saturation, both pre-ductal and the post-ductal saturations. So, and we kept invasive lines of 22 gauge 4 centimeter for the femoral arterial monitoring. Then we put optimal, we discussed with the NICU team what was the actual requirement, ventilatory settings. We recorded those things and we kept the humidifier at 37 degrees. Along with that, Jackson-Ree circuit was kept ready at the bedside. Before induction, baseline electrolytes, ABG, and blood sugar levels all have been checked and corrected appropriately. And we asked to cross-match and kept 15 ml per kg of blood and kept ready in the NICU. So surgical plan was to do the ligation in left lateral position by muscle sparing thoracotomy by the third intercostal space. And surgeon was going to put a large titanium clip with minimal dissections and then closing thoracotomy, routine thoracotomy closure over a 12-French vein. So coming to anesthetic management, we induced the patient with ketamine of 1 milligram per kg IV and injection fentanyl of 1 mics per kg and vecuronium of 0.1 milligram per kg IV. And the anesthesia was maintained with fentanyl infusion at 1 mics per kg per hour and as well as injection vecuronium top-up. Femoral line was secured with 22 gauge 4 centimeter on the left femoral artery. 2 peripheral lines are secured. So we put the ventilator setting peak inspiratory pressure so that we should get the tidal volume of 5 ml per kg with ventilator rates targeting to get that ETCO2 of 40 to 45 milliliter of mercury. And we adjusted the FiO2 so that we should get the saturations of 94 to 95%. While doing once the baby was covered completely, we kept a vigilance so that there should not be any dislodgement of ETT or any displacement of the lines during the positioning. So intraoperatively, lung retractions, because to reach the PDA, surgeon has to do the lung retractions. While he was doing it, we managed the ventilation by hyperventilation through the JR circuit with higher FiO2. And we communicated with the surgeon intermittently to release the retraction whenever we are finding difficulty to ventilate. And just prior to ligation, in order to prevent the rupture of PTA, we gave small dose of fentanyl, 1 mics per kg, so that we can decrease the BP surge. And once it is done, lungs were inflated manually prior to reb approximation, and the baby was placed back in the supine position. So PDA post ligation, there are many hemodynamic concerns. First is there is like acute hypertension, which can lead to intraventricular hemorrhage. So the patient care has been taken care that we should actively control the blood pressure. There may be post ligation cardiac syndrome. Usually it starts 6 to 12 hours post operatively, where patient may have cardiovascular collapse and pulmonary dysfunction. So care has been taken for that. While doing PDA ligation, maybe surgeon can do iatrogenic coarctation or inadvertent ligation of left pulmonary artery, and very utmost care has been taken so that PDA should not get ruptured. Otherwise, there will be massive bleeding, and controlling that bleed will be life-threatening. So after surgery, we did the echo immediately, transthoracic echo, to confirm the repair. On echo, there was no PDA, no coarctation of aorta. There was good flow in the branch PS, but we found there was severe LV dysfunction with systolic hypertension. So we started milrinone at 0.5 mics per kg per minute. And post-op pain management was done by fentanyl infusion at the rate of 1 mics per kg per hour. Asked for chest X-ray to see whether there is any pneumothorax, but there was no pneumothorax, as you see in this X-ray. So this is the baby. Yeah, you can see how tiny it is. And so concluding my topic, so operating on a sick preterm in the ICU, it requires knowledge, thorough understanding of the subject, competency, and impeccable communication between the intensivist, surgeon, and the anesthesiologist. It requires multidisciplinary approach consisting of cardiac surgeon, cardiologist, cardiac anesthesiologist, and intensivist. Due to such efficient cardiac team at SRCC, management of such complex case becomes definitely well managed, both intraoperatively, post-operatively. Thank you for your patient hearing.
Thank you so much, Lopa. That was an extremely high-risk case and very meticulously planned and executed. Next, I would like to call upon Dr. Saumil Sahasrabuddh. He is a junior consultant in anesthesiology, working in the cardiac anesthesia team. He's going to be presenting another challenging cardiac case. Over to you, Saumil.
Thank you, Naveed ma'am. Good afternoon, everyone. I am Dr. Saumil Satish I am a junior consultant in Pediatric Cardiac Anesthesia at NHSRCC Hospital. So, working in a tertiary care level, the tertiary care hospital, we come across a lot of challenging cases on a day-to-day basis. And today I'll be talking about one of my most challenging cardiac case. So, this was a 19-year-old male patient weighing around 51 kgs. He had history of intermittent tingling sensation over left arm since the past 1 year. He was a known case of cyanotic congenital heart disease and Klippel-Feil syndrome, having congenital cervical vertebral fusion of the C2 to C6 vertebrae with Sprengel's deformity. He visited an orthopedic surgeon with the complaints of tingling sensation over his left arm, but he was asked to correct the underlying cyanotic congenital heart disease first. He visited many hospitals to get his congenital heart disease corrected, but was deferred from all hospitals owing to his multiple congenital problems. He came to our hospital to get his cyanotic congenital heart disease treated, but he did not have any symptom regarding the same. Patient was diagnosed with a congenital heart disease at 1 month of age when he had symptoms of fast breathing and bluish discoloration of skin, but he did not undergo any treatment for it. He also had allergy of paracetamol. So this is the picture of that patient. So you can see very webbed neck, short neck, Sprengel's deformity in which the scapula are raised above the shoulders. And so he is scoliotic patient. Also on examination, the patient was conscious, alert, well-oriented to time, place, and person, having heart rate of around 96, pressures of around 110 by 70 millimeters of mercury, respiratory rate of 22, and saturating around 88%. He also had webbed neck and Sprengel's deformity, and mild cyanosis was present. On auscultation CVS examination, he had a pansystolic murmur and best heard at the left third intercostal space with grade 3 intensity. His respiratory symptoms, otherwise RS had air entry decreased bilaterally because of his scoliosis and the restricted scapulary actions. So other systems were quite normal. So if you see the photo, so there's a lateral view and an EP view of the patient. So the patient had Sprengel's deformity, webbed neck, short jaw, absolutely no extension of the neck, and also his positioning and everything was quite difficult. So when we did his echo, the echo findings were large Marland conoventricular ventricular septal defect with a bidirectional shunt. He had severe valvar and infundibular pulmonary stenosis. He had confluent and good-sized pulmonary branch PAs, dilated RA and RV, and he had a normal biventricular function and no major coronary crossing RBOT. So this is the CT image. So his MRI spine was done, which showed scalloping of posterior margins of C4, C5, C6, C7, fusion of lamina and facet of C4, C5, C6 of both sides, which is classical of Klippel-Feil syndrome. And he also had deformed spinous process of C4 and C5 with ill-defined osseous structure extending up to paraspinal region. His CT spine was done outside, which showed Sprengel deformity with loss of cervical lordosis and elevated scapula. So this is the X-ray image in which you can see the cervical spine, which is quite fused. And also there's a bit of scoliosis and he's having a boot-shaped heart, which signifies tetralogy of Fallot. So the challenges for this case were, first, he was a cyanotic congenital heart disease. He also had a restricted neck and shoulder movements, which causes a difficult intubation, difficult right internal jugular venous access, difficulty in positioning for surgery, difficulty in inserting a transesophageal echo probe, and difficulty in pain management because of his history of paracetamol allergy. This patient was electively planned for general anesthesia with awake fiber optic intubation, and we had done his preoperative spirometry training because it gets very difficult for the patient in the postoperative period to do spirometry, for which we already give a pre-op spirometry training to the patient, and we involve our physiotherapists for the same. He was also given a pre-medication of injection glycopyrrolate, a nebulization with 4% lignocaine, 10% lignocaine spray, nasal decongestion with xylometazoline, and a laryngeal nerve block. He was successfully intubated with a 6.5 cuffed endotracheal tube. His right radial artery and left femoral vein were cannulated. The surgery was successfully done on a cardiopulmonary bypass, and the patient came off bypass well. Post-operative echo, which was done in the OT, but obviously we couldn't do a transesophageal echo, so we had to do a transthoracic echo. Sorry, epicardial echo, which showed no residual VSD, no left ventricular or right ventricular outflow tract obstruction, free pulmonary regurgitation, and good biventricular function. This patient was shifted to the SICU on ventilatory support and inotropic support and electively ventilated overnight in the ICU. Patient was extubated on post-op day 1 after confirming the echo findings, chest X-ray, vitals, and drain output. So we kept in mind a lot of things before his extubation, owing to his difficult intubation. So fiber optic scope and difficult intubation trolley was kept as standby during his extubation. His extubation was planned in daytime at routine hours when everyone from the department was down. He was sent to the ward on post-op day 3 and discharged from the hospital on day 7. So this was one of my most challenging cases which I faced in cardiac. Thank you.
Thank you so much, Saumil. That was a very nice presentation. Next, I would like to call upon Dr. Vedhika Shanker, Junior Consultant Anesthesiology. Vedhika is going to be talking about management of perioperative analgesia, a pain-free promise. Over to you, Vedhika.
Thank you, Dr. Naveed. My topic today is managing perioperative analgesia, a pain-free promise. And before we get into just a minute. All right. So before we get into how we manage pain, a little bit of an introductory entry into what exactly is pain. As we all know, it's a very common adage, pain is the fifth vital sign, but it is more than just a vital sign which has, an X or a Y axis. Pain is considered an overall experience. The International Association of Pain Study of Pain in July of 2020 defined pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, what is very key here is that as soon as the definition is put out, you realize that it does not always have to be associated with actual tissue damage. A patient's perception of pain is enough. So along with this definition that was modified in July of 2020, there have been a few more caveats that have been added. Pain is always a personal experience. Pain and nociception are different phenomena, meaning that the sensation of pain is not exclusive to feeling pain. Through life experiences, individuals learn the concept of pain, meaning that their personal experiences have modified their perception of pain. And a person's report of an experience as pain should always be respected. So moving on to the burden of pain in pediatric patients. So how much exactly are we looking at in terms of pain and its involvement in a day-to-day pediatric hospital and its practice? So pediatric patients, the pain experience extends to the family as well. Data from Children's Hospital reveals that pain in pediatric patients is not only common, it is often under-recognized and undertreated. Exposure to severe pain without adequate pain management has negative long-term consequences, include increased morbidity, mortality, behavioral disorders going forward. And study in NICU patients says that those patients undergo an average of 7 to 17 painful procedures per day. This includes physiotherapy to chest, venipunctures, intubations, NIV. Exposure to pain in this age group also leads to higher pain self-ratings during venipuncture by school age, poorer cognition as well as motor function. So the long and short of it is inadequately managed pain leads to long-lasting consequences in terms of increases in the risk of developing problems in adulthood. Acute pain. Acute pain is defined as the expected physiological response to a noxious stimuli. This could be chemical, thermal, or mechanical, and usually accompanies visible expected trauma in the form of surgery, injury, tissue damage, or inflammatory process. Acute pain, by definition, is self-limiting and typically resolves over days to weeks, but it can persist longer as healing occurs. Untreated acute pain may lead to fear and even avoidance of future medical procedures. The mainstay treatment of acute pain is multimodal analgesia. I'm sorry for bringing in so many definitions, but it helps, going forward with how we understand how we treat pain. So multimodal analgesia is defined as the concurrent use of separate therapeutic intervention, each of which have different mechanisms of actions. Thereby, you have different mechanisms of actions for not only treating the pain, you also limit the side effects from each medication or mechanism used. Prevention and treatment of acute pain is, as I mentioned, multimodal analgesia, and this is done via medications, regional anesthesia, rehabilitation. This can be pre-rehabilitation as well as post-operative rehabilitation. Psychological help in the form of cognitive behavioral therapy, visiting a priest can also be helpful, spirituality, integrative or non-pharmacological modalities. However, when it comes to acute pain, the last two are the least effective in terms of return on investment of use in pain management. Chronic pain, as defined, is intractable pain that exists for 3 or more months. When it comes to pediatric patients, the 3 months definition is not really considered admissible, and it is hence been defined as pain that extends beyond the expected period of healing, and hence lacks the acute warning function of physiological nociception. So any pain that lasts beyond the expected time duration and causes an interference with day-to-day life or day-to-day activities is defined as pediatric chronic pain. A study done out of Toronto says that 1 in 5 children are impacted with chronic pain. And a conservative estimate that posits that 20 to 35% of children and adolescents are affected by it worldwide. This, however, the non-pharmacological methods will be the mainstay of treatment before you move on to opioids. So here we begin with rehabilitation, integrative mechanisms, psychology, and what is very important is that you normalize life. Pain does not improve before you get back to life. So it's very important to convince children that they need to get back into their activities of sports, going to school, involving themselves in social life, and then pain goes down. And of course, in the initial periods, you have to use medications. However, this comes in the exact opposite way, whereas we have non-pharmacological techniques forming the absolute basis of chronic pain management. It is the last option that we use in acute pain management. But what is important is that you use multiple techniques to manage pain in any and all forms, acute as well as chronic. So our role as an institute, NHSRCC Children's Hospital is a JCI accredited institute, and this is a report, the R-Cube report that has been published for all Joint Commission accredited organizations. Now, what this mentions is that every hospital that is JCI accredited has certain responsibilities that they would need to fulfill. And this is subdivided into various aspects. So when it comes to pain management, what is required from the leadership is that there should be, first of all, a leadership team. The hospital should provide mechanisms for non-pharmacological pain management. They should have licensed staff and physicians available who can manage pain, as well as educational resources that can help patients. When it comes to medical staff, they say that all staff must be actively involved in pain assessment as well as pain management. When it comes to the provision of care and treatment, there is a lot that has been mentioned about opioid safety, how to track opioid use, as well as any adverse outcomes that happens to patients due to the prescription of opioid. And as always, there is always a role for performance improvement. All hospitals that are JCI accredited are required to collect data on pain assessment and management, analyze the data collected, and see where they have room for improvement. So when it comes to pain, now we get to the meat of the matter. One must first identify pain in order to be able to treat it. So this is an article that talks about the various scales and tools that are used for pain assessment. Many of them, as you can see, there are lots of citations. Many of them are used, very well validated scores. In our hospital, I'll mention what we use. So when it comes to preterms and neonates, or rather, because children vary across multiple age groups with different personalities, and various developmental stages, you need different pain scales for different age groups of patients. So when it comes to preterms and neonates, of course, there's not going to be any verbalization of pain. So we have to rely on other forms of getting pain information. What is used in our hospital is the NIPS, or the Neonatal Infant Pain Scale. It is simple. What has changed is there is a NIPS revised form where they have removed the physiological parameters. So you can use either of the same. This is a picture of our NICU chart, which has a scale and rating for the NIPS. And this is monitored every 4 hours. For premature infants, though the NIPS scale is validated for neonates and infants, premature infants are a little more complex and require a little more intensive pain monitoring. So you can use the premature infant pain profile. This is far more comprehensive, requires more education in terms of how to utilize it, and it is more frequently done. So cries can also be used. Infants and toddlers, here it gets a little easier. Children's facial expressions are easier to read. You can use the CHIOP scale, or the Children's Hospital of Eastern Ontario Pain Scale. What we use in our hospital is the FLAC, or the Face, Leg, Activity, Cry, and Consolability Scale. This is a sample chart of one of our patients. This is how we document the FLAC scale, and it is documented every 4 hours after a procedure. So preschool and young children, 3 to 7 years old, it gets a little easier. These patients are able to communicate how they feel with us. So you can use the FLAC, but what we normally use in this age group is the Wong-Baker Faces Pain Scale. So this is again a sample of one of our hospital charts and its documentation. This is where you ask the child, look at the child's face and assess a number as per the Wong-Baker scale. There are multiple such faces pain scales that can be used. What is more important than knowing the entire gamut of pain scales is applying one and using it universally throughout the perioperative period of the child's admission. Better yet, have one scale for each of these age groups and apply it universally throughout the hospital. So you can have data that you can compare to the pre-op as well as post-op for the same patient, as well as compare pain scales between patients. Now, moving on to pain management strategies. The ladder that we see here on the left, everyone should be familiar with it. It is the WHO analgesic ladder. It is simple. It is very easy to see. For mild pain, you have non-opioids plus minus adjuvants. That would be your acetaminophen and NSAIDs. As the pain gets worse, you incorporate opioids, and then you use opioids and adjuncts. While this is very simple, it is a little hard to translate it directly to children because when it comes to children, everyone is a little nervous about treating pain. So this is an alternative example that I can give for how you would grade your effectiveness of pain management. The European Society of Pediatric Anesthesia, ESPA, has generated their own pain ladder, but instead of stratifying pain, they have sort of allowed the practitioner who is treating pain to evaluate their own sort of ability to manage this condition. So the primary goal is to achieve at least a basic level of pain management where all children in the hospital undergoing surgery achieve a reasonable level of pain management. So this is the basic level. Once you have achieved the basic level, then you can aspire or move on to the intermediate and then advanced levels. And as you keep increasing, or rather going from step to step, from basic to intermediate to advanced, this would require more staff, more complexity, and more technical equipment and infrastructure. So this is an example of how quality improvement can occur with the ESPA pain ladder. Step one would be every child undergoing surgery would have a written individualized standard prescription for pain management. You won't just write, for example, injection paracetamol. You'll have to mention the weight per kg, the number of times it is dosed, and for how many days it is dosed. You have achieved your ideal when every patient undergoing surgery receives a written individualized standard prescription. Step two is frequent pain assessments. This should be done at least 3 times a day. Step 3 would be once you have pain management, you should be able to say that every patient under your care has a pain score that is less than 4 by 10 for as much time as possible. Step 5, 4, and 5, expect that you would reevaluate, check for improvements, and make changes, and again go to reevaluation. So a very simple example is A circumcision, it's a standard procedure. So, for example, a basic level of pain management for any child undergoing a circumcision would be the use of a rectal NSAID. If that is not available, a rectal paracetamol, and a surgeon-administered penile block with a long-acting local anesthetic. So if you were to say move on to an intermediate level, you can use rectal NSAID or a paracetamol and a penile block or a caudal block in this case. An advanced level would be using the same medications, but advancing oneself to giving an ultrasound-guided penile block or ultrasound-guided caudal block. The idea is once you've achieved the basic level, for everyone admitted under your care, you try to move on to an intermediate level and then move on to advanced. So when it comes to multimodal analgesia, we've already gone over what are the 6 strategies we have in our armamentarium. Medications form a very large part of our postoperative pain management, but what becomes difficult for most people when administering pain management is the pharmacological differences between adults and young children, and especially neonates, when it comes to metabolization and management of these medications. So neonates and young infants have delayed maturation of hepatic enzymes, which causes a prolonged duration of action as well as a increased risk of side effect profile. The glomerular filtration and renal tubular secretions are reduced, meaning that there's a slower elimination of opioids and their active metabolites. Neonates and young infants also have reduced levels of alpha-1 acid glycoprotein and albumin. This leads to decreased plasma protein binding for many drugs, including local anesthetics. Infants have immature ventilatory reflexes and responses to hypoxia and hypercarbia, and hence have an increased risk of hypoventilation in response to opioids. All of these factors we know, and we understand why people would be wary of administering opioids to young children. So outside of opioids, what else can we safely use to treat pain? Of course, we have the most commonly used paracetamol. Then we have NSAIDs. We also have alpha-2 agonists such as clonidine and dexmedetomidine. And we also have adjuvant medications that can be used if the above have not provided adequate pain coverage. So coming to paracetamol, it is the most widely used. It's very safe. It's effective for mild to moderate pain only with a good safety margin and does not cause any respiratory depression. Oral dose is 10 to 15 mg per kg. Rectal route has a slow and variable absorption, so when preferable are oral and intravenous route. So recommended rectal dosing is typically 30 to 45 milligrams per kg, followed by 20 mg per kg every 6 hours. When it comes to intravenous for preterm neonates, it is 7.5 mg per kg per dose. Neonates is 10 mg per kg. Infants and children is 15 mg per kg per dose, given QID. That is 4 times a day. Now, NSAIDs, all of these medications have proven use in children and have been proven to be safe. These are prominent anti-inflammatory and good and effective for moderate as well as mild pain in post-operative or peri-operative period. NSAIDs are effective, as I mentioned, against moderate pain. So while they are effective, they are more effective in preventing pain than in the relief of established pain. So what becomes very important is rather than writing, say, an ibuprofen or a diclofenac SOS, ensure that the patient receives an NSAID round the clock in the perioperative period, at least for the first 48 to 72 hours following surgery. Here it is far more effective. It is easier to manage, it is easier to keep the patients on NSAID round the clock than to attempt to manage breakthrough pain with an NSAID. So using 2 NSAIDs has shown to have no benefit, but combining paracetamol with an NSAID has shown to have cumulative analgesic efficacy. Common question is which NSAIDs are safe to use in under 2 years? Going through the literature, what we have a lot of information for and what we know is safe to use is ibuprofen is safe to use from 3 months and on, diclofenac from 1 year and up, or you can even say above 10 kgs and up. Ketorolac is safe to use from 6 months and up, however, it's only available intravenous. And of course, indomethacin, we have a lot of data from the neonatal period. However, there are side effects to using indomethacin, but in a risk-benefit ratio, it is used in NICU for closing patent ductus arteriosus. But the safest NSAIDs, as I mentioned, are ibuprofen, diclofenac, and ketorolac. Dispelling some common myths, despite marketing claims to the contrary, NSAIDs are fairly similar to each other in peak analgesic effect when administered in equitoxic doses. No evidence exists that any NSAID or selective COX-2 inhibitor is stronger than older agents such as ibuprofen or naproxen. There is no magic associated with parenteral routes. Ketorolac is not uniquely stronger than any of the oral NSAIDs as an analgesic. Safety profile. As we all probably know, NSAIDs, we have a risk of nephropathy, gastropathy, and bleeding caused by platelet dysfunction. However, this is reversible in all cases except in the use of aspirin. In general, short-term use of NSAIDs is well tolerated by children with low incidence of side effects. The risk of renal and hepatic toxicity are increased by hypovolemia or cardiac failure. Prolonged use of NSAIDs incurs a significant risk of GI bleed, although with a still lower risk of overall compared to that of adults. Most available information regarding pharmacokinetics and safety of NSAIDs in neonates has been derived from the studies of their use for a closure of a PDA. And as we already know, indomethacin is safe to use in this regard. So when it comes to selective COX-2 inhibitors or the newer NSAIDs, are they specifically beneficial? There is no difference in terms of renal parameters or no difference in terms of GI bleed when they're used. However, they do tend to be more thrombotic in terms of compared to other classical NSAIDs. So for certain subgroups of patients, for example, children with hemarthrosis caused by hemophilia, there is a benefit to using COX-2 inhibitors because there is less risk of bleeding seen with selective COX-2 inhibitors. However, for other groups or vulnerable patient groups with decreased blood flow due to either Moyamoya's disease, Kawasaki's disease, probably better to avoid COX-2 inhibitors. Now, opioids. As I've already mentioned, there are renal system is immature, the liver is immature, and they are more prone for respiratory events following the administration of opioid. This is how you would use intravenous. Most commonly used opioid is morphine. You start with a bolus of 0.1 mg per kg every 2 to 4 hours and then set up an infusion at 0.03 mg per kg per hour. If you're giving oral morphine, start with 0.5 and you can always titrate up. The duration of action is about 4 to 6 hours. Fentanyl is only available intravenously and can be safely given at 0.5 mics per kg, and you can titrate upwards towards up to 2 mics per kg per hour in an infusion setting. Always be aware that any opioid can have respiratory depression and be ready to handle this if that happens. Tramadol is a synthetic analog of codeine which acts via opioid receptors. It's an excellent rescue analgesic. However, its use in children is considered a little controversial. The FDA has a black box warning against its use in children under 12 years due to certain patients who have had respiratory depression and have had fatalities because of its use, specifically in post-tonsil and adenoidectomy surgeries. So use tramadol, but do so with caution, as you may have a small subset of patients who are rapid conversion of tramadol to its metabolite, which causes significant respiratory depression. Transdermal opioid patches should never be used in an opioid-naive patient. I also know that when you've applied a patch, the levels take about 12 to 24 hours to achieve necessary steady state. And even if you remove the patch, it takes another 12 hours for levels to come down. They're typically used in cancer pain with chronic and more of a constant level of pain. Regional analgesia and anesthesia, this is becoming very popular, especially in children nowadays, thanks to the advent of ultrasound. These can be site and procedure-specific analgesic modality. They can be neuraxial, that is either caudal or epidural. They can be given as a peripheral nerve blockade or as a facial plate block. These are opioid sparing, can be highly specific to the case. They have a high success rate, very safe, and extremely efficacious in managing pain. So this is giving a wrist block for a patient undergoing a wrist surgery. This is an axillary block being given under ultrasound guidance. And this is a maxillary nerve block being given for a cleft palate surgery. You can see here's the ultrasound probe, and this is the needle entering and depositing drug. These are extremely safe, of course, there is a steep learning curve, but it can be learned and training is available in multiple centers. We train fellows in regional anesthesia techniques as well when they train in pediatric anesthesia. So when it comes to the risk and safety profile of regional techniques, there are two massive studies, the ADAPF and France studies, and the incidence of complications is less than 1%. Non-pharmacological methods, they don't have much of a role in acute pain, but there is no stone too small to leave unturned when it comes to pain management for children. So these can be used and they're quite simple to apply, as simple as a pacifier being given to a child who's undergoing an awake hernia surgery under a caudal block. Using local anesthetic patches and then distracting the child at the same time using technology or movies or TV, swaddling the child if it's a small baby. All of these methods can be used in adjunct, of course, to your mainstay methods, which are your medication and other regional analgesic modalities during surgery. So how we approach a child under surgery, one is when a regional analgesic block is possible. Our mainstay of analgesia intraoperatively at that point is a regional block, which can either be a neuraxial, a facial plane, or a peripheral nerve block. We use injection dexamethasone, which it also is anti-emetic activity as well as anti-inflammatory and also contributes to analgesia. Paracetamol is given in all patients unless contraindicated. Same with NSAIDs are given to all patients above 10 kgs in weight, above 1 year of age. Case by case basis, we also use other adjuvants such as IV lignocaine at 1.5 mg per kg, magnesium sulfate at 30 mg per kg, and alpha 2 agonist dexmedetomidine at a rate of 0.5 to 1 mic per kg per hour. Now, say suppose a regional block cannot be used, we follow the same medication management, that is a paracetamol, an NSAID, and a steroid, along with the same adjuvant medications that we would use in another case. If we were to rescue a patient who's received a block, either we can attempt a rescue block when feasible, but however, an awake patient giving a block is difficult because it requires ultrasound use and a needle. So other options include opioid medications, which are tramadol 1 mg per kg or injection pentazocine at 0.5 mg per kg. In conclusion, pain is the fifth vital sign for a reason. It contributes to a patient's entire hospital experience as well as their families. It has an overarching impact beyond just a single patient. It impacts quality of care, perception of treatment, cost of treatment, complication rates, length of hospital stay, as well as behavioral impact post-operatively. Frequent assessment and reassessment of pain is essential. Common scales across should be used across whatever hospital you practice in. In our hospital, we use the NIPS for neonates, the FLAC score for preschool and toddlers and infants, and Wong-Baker Face Scale for children over 7 years. Pain team or an acute pain service is essential. It is also very important that you have established leadership for the management of pain in the hospital so that there is a single dedicated team that manages pain management and its associated difficulties. Thank you so much.
Thank you, Vedhika. Pain forms such a core concept in anesthesia, and your presentation regarding it was highly detailed and very exhaustive. On a side note, I am requesting all those attending to please put your questions in the chat box because we'll be having a question and answer session after our next lecture. So the next presentation is by Dr. Herrick. He is a consultant anesthesiologist and he's going to be talking about pediatric anesthesia beyond the horizon. Over to you, Herrick.
Thank you, Naveed. Good evening, everyone. I'm Dr. Herrick Shah. I'm a consultant over here at SRCC Children's Hospital in Pediatric Anesthesia. And today my topic is Pediatric Anesthesia Beyond the Horizon. So till now, the pediatric anesthesia basically began way back in the 19th century, and it was associated with a rural physician named Crawford Long, who in 1842 recorded the first case of giving diethyl ether anesthesia to an 8-year-old boy. Since then, we have seen a lot of development. So it is basically divided in two parts. First is the anesthesia techniques and accessories were developed to adjust at different age groups, because our the patient population which we cater to ranges from a day one neonate to an up to 18 years of age. And second was the modern anesthetic medications and supervision was introduced into everyday clinical practice to better protect the vital organs and their functions. So now beyond the horizon means what next? So till now we have relied on our expertise and intuition to guide patients through surgical procedures very safely. Now the next best thing is to integrate technology and artificial intelligence and to revolutionize the field, promising enhanced patient care, improved efficiency, and reducing the risk. So I'm going to talk on predictive analysis, advanced monitoring, automated drug delivery systems, robotics and AI-assisted procedures, and gamification of medical training. So the OR and the pediatric ICU, they are data-rich environments where fast decisions are to be made based on monitoring physiological variables for maintenance of physiological homeostasis as well as recognition, prevention, and treatment of complications. So with the help of machine learning and AI, we have developed predictive tools for pre-operative, intraoperative, as well as post-operative period, which includes like airway equipment planning. Then for intraoperative purposes, we have models which can predict which patients can have increased chances of respiratory complications, blood transfusions. We can also predict for risk opioid requirements for each patient separately, and so on and so forth. Then coming to monitoring. So in this, we can see initially we used to do pulse and blood pressure monitoring only. Then we got an electronics era came in around 80s and 90s, where everything was clubbed into one thing. And then by 2000, we had connectivity and integration where the devices were miniature, sensor-based, guideline-based, and point of care. Now, what the future looks like is we are going to have consumer-based hardware and technology, smart autonomous devices. I'll give you an example. So these are some few examples where advanced sensor technologies have been used. So they are non-invasive and implantable sensors. Non-invasive are wearable devices and smart patches, which will allow for continuous monitoring of vital signs, including heart rate, blood pressure, and oxygen saturation. Implantable sensors can provide real-time data on physiological parameters such as intracranial pressure, cerebral blood flow, and enabling more precise and personalized care. And to integrate all this, we need Internet of Things in anesthesia care. So what we do is we get continuous data streams, devices which commonly monitor all these vital signs, and they are all connected to a server, and this server we can connect to this server and we can have the same readings on our phone. We can also have early warning systems where AI powered analytics can identify trends and anomalies in patient data, alerting clinicians to potential complications early on. And this slide looks a little busy. So this is basically showing depth of anesthesia monitoring and nociceptive monitoring. So currently for depth of anesthesia monitoring, we have EEG or processed EEG based techniques, which is the most commonly used. And it helps in reduction in anesthetics use, faster emergence, shorter stay in post anesthesia care unit, and better hemodynamic control. And for nociceptive monitoring, currently strategies used are pupillometry, analgesia, nociception index, surgical plethysmographic index, etc. So what the future holds for these two monitorings are we'll have a better personalized care. Then we can also, what we can probably by 2050, we'll have a near perfect analgesic drugs, unlike opioids, which will not depress our respiration and have effects on the cardiovascular system. And all these things can help in better monitoring and analgesia. Then use of artificial intelligence in pediatric airway. So these are a lot of studies have been undertaken where a computer model is used to predict difficult airway from analysis of facial structure. We also have machine learning models for endotracheal tube size prediction. We have machine learning model that can predict intraoperative hypoxemia events 1 minute ahead in children undergoing general anesthesia. So all these Advanced technology and AI models will help us for better care. Then we also have virtual and augmented reality training. I'll just play a video to help understand better. So this is an VR based laryngoscopy and intubation training, where you can see even you can select your patient. It can be a pediatric, geriatric, until there are instructions displayed how to go about intubation, and this is how you practice and before you can actually do an intubation on the patient. So this is Spiro's handheld AI-guided intubation robot. So basically this is like a hybrid technique for intubation where two cameras are used, and I'll show a video.
So we've invented a solution for this, and it's called picture profile. It makes it picture over reproducible that regardless of the patient and regardless of skill level. We'll have a year 100% first pass success rate, and we're expecting 90% reduction in complications associated with intubation. Next slide should give you a video of your right approaching argument. Starting by skin roughly 7 and articulate 360 degrees. And this allows you to get anywhere it needs to go to in the airway. Next, the video we intubating we did. And so I think this one is just like you find now you have to do a think about it. Very big and absolutely correct. And all the question has to do the fact and into over the endoscope the patient's intubated.
So such devices will help us with all sorts of difficult airway. Then coming to optimizing and placement of supraglottic airway. So these are one of the best devices which were invented, and they really help us when it comes to rescuing the airway where we are not able to intubate the patient. So currently what we do is we blindly insert the supraglottic devices, and optimal placement is only in 29% of the cases. So the challenges we face is it is very difficult to correct a malpositioned supraglottic airway, and inappropriate usage even upon not meeting the clinical criteria. And there is no method to evaluate the placement. So currently what we can do is we can use video laryngoscopy. It allows verification and adjustment of position. Then fiber optic examination after verification of positioning. Then coming to robotic anesthesia. So here you can see this picture. So we have something called as a pharmacological robot, and we have something called as a mechanical robot. Pharmacological robots are basically closed loop systems where the patient's vitals and anesthesia depth and nociceptive indexes are measured, and the anesthesia rate and the drug rate is adjusted accordingly on its own based on the algorithms. And then a mechanical robot is something which helps us with intubation and peripheral nerve block and other procedures. So first coming to closed loop control systems, basically it has four parts. First is a continuous monitoring where advanced sensors are continuously monitoring a patient's vital signs, heart rate, blood pressure, saturation, end-tidal CO2 and depth of anesthesia. So this data is collected and analyzed by algorithms to assess the patient's current state of anesthesia. Then the third part is the automated drug delivery system. So based on this analysis, the system automatically adjusts the delivery rate of anesthetic agents such as propofol, remifentanil to maintain the desired level of anesthesia, and there is a feedback loop. This system continuously monitors the patient's response to the administered drugs and adjusts the delivery rate accordingly, creating a closed loop system. This is more or less what it looks like. So these are the two models which are available. First is a MexSleepy model. So it monitors the patient's level of consciousness, pain, as well as muscle movement throughout the course of surgery and adjusts the levels and dosage of intravenous agents. Currently, the algorithms are based for 3 drugs, namely propofol, remifentanil, and rocuronium. And second is a sedasis device. It is an automated sedation system in an endoscopy suite. So this is also a closed loop using an auditory or vibratory command module that asks the patient to squeeze a handheld switch, and accordingly they can increase or decrease the dosage of propofol. So this is another closed loop system where along with the anesthesia, there's also hemodynamic control. So they analyze the stroke volume index, the stroke volume variation, and CVP, and they can also it gives vasopressor and fluid boluses accordingly. So this is like a more complete closed loop system where there is anesthesia as well as hemodynamic control involved. Then coming to mechanical robots, there's something called as a Kepler intubation system, which is a robotic system designed to assist with endotracheal intubation. So it has a robotic arm and a video laryngoscope which gives clear view. So it has three modes. The first is a direct view where the anesthesiologist has a direct view of the patient, uses the robot to assist with intubation. Second is the indirect view where the anesthesiologist operates the robot from a remote location, viewing the patient's airway through a video laryngoscope. And third is a semi-automated where the system can perform some intubation steps automatically, such as inserting an endotracheal tube. So this is the joystick, and you can see on the screen the airway. This is the Kepler intubation system where you can see a robotic arm and the anesthesiologist operating from far away. Then coming to artificial intelligence in regional anesthesia. So ultrasound imaging is the most important advance in regional anesthesia practice. USG being a dynamic imaging modality, the quality of the views obtained depends on the skill of the operator as well and the image generated by the machine. So automation and AI can help with better image quality, landmark identification, needle tracking, and visualization. So I'll just show you a few examples of each. So the first, this model is the U-side model, where so a lot of times when we're giving a central neuraxial block, palpating the spine may not be always be possible for various reasons. So such software and programs will help us identify the center as well as the exact intervertebral space. There's one more. So next is something called the handheld device called Accuro Automated Neuraxial Imaging Guidance. I'll show you a video of that as well. So this is a handheld device where it shows you the depth of epidural space as well and where exactly to go. So all these newer advances help us identifying spine, the intervertebral space, and makes regional and central neuraxial blocks much easier. So you can see here this number, which is 4.7, it shows how far is the epidural space exactly from the skin. So we know we are not supposed to insert the needle beyond this number. Here you can see it also has live image guidance where it shows the exact path of the needle and the depth of the epidural space. So next, this is something called as an overlay technique, where sometimes you are not able to exactly accurately identify the neural structures. So it gives a color overlay on different structures. This is a video of this. So here you can see this is the bunch of nerves. Once you press this nerve, you have a yellow color on it. And as and when you move the probe and the nerve changes, the color follows the nerve and you know exactly where to deposit the local anesthetic. Next is gamification in anesthesia. So principal applications for So principal application for gamification, anesthesia, pain medicine, critical care include simulation where scenarios for airway management, including intubation, difficult airway situations, and emergency maneuvers are there, regional anesthesia. So what you can do is add a level of scoring system where if you're doing all the things correctly as per the protocol, you get better score. And this is one way of developing protocol-based training for everyone. It is also used for patients where you can have a VR based module for them, where they will come to know exactly how the OR looks from the inside, who all will be there. You can have different avatars built in the VR, so they know how to interact. Then lastly, coming to the ethical considerations of AI. So there are a lot of ethical considerations of AI in anesthesia. The first and the most important is the patient privacy and data security. So AI-based systems will require large amount of storage of patient data, raising concerns regarding privacy. Then also regarding consent, clear and transparent informed consent processes will be essential. We can while developing algorithms, we can also have algorithmic bias and which will affect the training. Then coming to, we'll be also over reliant on AI. So we'll also lose the human touch and our intuition. Now, obviously liability and accountability. And last is access and equity. So we have to ensure that there is an equitable access to all AI powered anesthesia care to all the patients coming from all strata. Thank you.
Thank you, Harik. That presentation was an eye-opener. We are looking forward to pivoting all these innovations that you have talked about. Next, we'll be having a question and answer session. I would like to invite Dr. Vaibhav Dhabe, who's a senior consultant in anesthesiology. And I request all of you listening to please put your questions in the chat box. Over to you, Vaibhav, sir. So one of the questions that we have is regarding pain management in cardiac surgery.
So we have all the spectrum of cardiac surgeries operating at our place. Though there are recently we can use some regional anesthesia like paravertebral block, erector spinae muscle block. So these are the facial plane blocks which are used for pain control and early extubation of these patients from ventilators. We at our center sometimes use caudal morphine plus dexane to patients for fast tracking, or most of our patients are on fentanyl infusion plus dexane infusion. So this normally suffices if we are doing okay and early extubation in post-op cardiac care unit. We are using now the paravertebral block and erector spinae block in thoracotomies, but we are at present not using a lot of regional in our unit. So we are basically dependent on NSAIDs and opioids for our pain control, which is giving us focus out of our.
Thank you so much, sir. There is another question regarding what sort of daycare surgeries are performed in SRCC.
So daycare forms an important part of pediatric care, which is which helps all family in toto for procedure. So for daycare, major important thing is patient selection. We have a specific facility for daycare procedures where we have staff and post-op care unit for daycare. We give idea about the procedure and the PACs and all the pre-op considerations are taken care of pre-operatively before the procedure. Patient is admitted on the day 2 hours or 3 hours prior to the surgery, depending on their convenience. And then they are discharged after the procedure. if they meet specific criteria. So daycare is important, but the patient selection is very important in the daycare.
Okay, thank you so much, sir. I kind of have a question of my own that now that we are a part of tertiary care hospitals and we have a lot of critical patients undergoing a lot of very complex surgeries. So I'm sure some percentage of them might not be very happy in case a child is not doing well. How do you, what are your ideas for some better counseling regarding these kind of patients and their parents?
So this kind of situation arises majority of the time in major cases or very complex cases. For example, cardiac cases or a transplant case or a major scoliosis case. So the management of such situation starts from pre-op counseling only, where the parents need to be told that the post-op course of the patients can be challenging, but we have all the specialties and people available 24/7 taking care of the kid according to the need. So if, for example, we have a cardiac kid who goes somewhere who has some neurological complication, unfortunately. So we have a neurologist who will look into it in time and we will try and manage it. But the idea is given pre-op. The parents know about the situation pre-op and then they kind of cooperate with us in a better way. If the situation is sudden and if they are not expecting, then the responses are like which you are not expecting and they can be little non-cooperative sort of. But we have to have this pre-op counseling plus on daily basis if patient goes into the ICU, each day, each parent is counseled by the intensivist separately, giving him the update on the patient's condition and whatever the plan of the our team regarding that patient. So then the things go on smoothly. Thirdly, we have meetings like joint meetings of various specialties, and for cardiac we have cath meetings which preoperatively help us deciding the plan and what are the complications we expect post-op, so that all the multidisciplinary people are involved from pre-op. For example, we had one patient, when the patient had sickle cell anemia, so we had a hematologist involved from pre-op, intra-op, and post-op looking into patients, making the journey of the patient, and they also are in contact with the parents. So the parents also know if they are taken care of and the journey is smooth and the output is good.
Thank you so much, sir. I think that are all the questions that we have. I thank everyone attending for their kind attention and patience, and we'll be ending the meeting here.